Welcome. We will allow another minute for others to join before we get started. Sherry, if you want to move to the next slide. Hello, and welcome to the HQuick Sepsis Affinity Group. Thank you for taking the time out of your busy schedule to participate with us today. Our goal for these sessions is not only to provide you valuable education and resources, but offer a forum for open dialogue on the challenges and successes you've experienced. We encourage you to share openly during our discussion time. Next slide. Before we get started, I want to first go over some logistics for today's collaborative call. If you have a question, please click on the chat icon and enter your question there. You can also raise your hand under the reactions icon at the bottom of your screen if you'd prefer to ask a question verbally. If you need to adjust your audio, you can click on the caret next to the unmute icon. And finally, a recording and a copy of the slides from today's session will be shared. Next slide. And now I'd like to introduce our speaker for today's session. Deb Smith is our infection preventionist for Health Quality Innovators, as well as a quality improvement advisor for the HQuick program. Deb has more than 20 years of experience as an infection preventionist, registered nurse, and ASCP registered microbiology technician. She's a member of the Virginia chapter of APIC, and she holds her certification in infection control, and she's a certified professional in healthcare quality. And now, Deb, I'll turn it over to you.
Thank you, Karen, and welcome everyone to the first HQuick Affinity Group focusing on sepsis. This first session topic will be rapid identification of signs and symptoms of sepsis to reduce mortality. Next slide. We're going to begin the session with a high-level review of the quality improvement process, including building your sepsis team, gaining leadership, support, identifying sepsis champions, and setting your goal. We'll continue with identifying at-risk patients for sepsis in the ED, ICU, and medical floors, and then discuss follow-up and next steps. So you'll notice that extracting data and meeting the bundle compliance measures is not included in this first session. We'll be covering that in the second session with a subject matter expert from the field. Next slide. So why did we pick sepsis as the focus for the first affinity group at HQuick? Using a data-driven process, we reviewed our network data reports, and they show that we have the greatest opportunity for improvement in the sepsis mortality measure. This means if we reduce the measure, we save lives. We know through research that there is a variation in practices among hospitals. There can be still be some poor compliance overall with known quality indicators, and standardization in practices is needed. Focusing on collecting baseline data and following the progress through data improvement can help you improve your clinical practices and ultimately improve sepsis survival in your hospital. Next slide. All successful quality improvement projects begin with a goal and continue with the development of an action plan and implementation timeline. One of the most important steps in this process is identifying a leader who will support and sponsor the project. Many of you have mentioned during your monthly QIA calls that sepsis is an organizational goal in your hospital. That makes it easier to gain leadership support. But if sepsis is not already an organization goal, you can approach leadership through a data-driven discussion using the monthly data shared with you and your team for this project. You will also need to identify champions who will join your team or work with your team on an ad hoc basis. Then you can start developing your goal and working through an action plan and timeline for implementation. Next slide, please. Many of you have your own hospital action plan template, and that's fine to use and then share with your quality improvement advisor to review on your monthly calls. HQuick also has developed an action plan template that includes links to recommended quality improvement tools to assist you and your team to work through an action plan in an organized way. We have a sample of an action plan for sepsis that may help you think through this process. Your quality improvement advisor will be happy to share this with you and begin to work through the action plan with you on your next meeting. Next slide, please. One of the QI tool links in the action plan is a 5 whys tool that includes a fillable area to document your identified root causes. Working together with your team and using the 5 whys process to drill down to the root cause of the problem helps the whole team feel like a part of the process and show ownership in the outcome. Next slide. After identifying your problem and root causes, you can go on to use this goal setting worksheet, which is another helpful tool to use with your team to set a specific, measurable, attainable, relevant, and time-bound goal that everybody on the team agrees with. Next slide. The HQuick action plan template continues with columns to document your specific actions and interventions, any baseline data and data goals for that intervention, a timeline for completion, and the team member responsible for that intervention. On this sample sepsis action plan, we've provided tools and resources in the comments section to support the sample interventions. You and your team would customize your action plan for your specific hospital. You can ask your quality improvement advisor to review your team's action plan with you on your next monthly call. Discussing your plan with your QIA helps to validate your plan and move it forward so you can progress through the plan to completion and sustaining your improvements. Next slide. So I personally like to use a gap analysis tool whenever I'm asked to lead a quality improvement project. We do have this high-level sepsis gap analysis tool for hospitals, and we're asking all of you to complete this gap analysis by next Friday, August 13th. So that's easy to remember. It's going to be Friday the 13th. There's a link provided here on this slide, and also a link will be provided in chat. The HQuick team at HQI will use the aggregated results of this gap analysis in developing additional tools and education for the sepsis affinity group and for future work sustaining sepsis mortality reduction. The gap analysis really shouldn't take any more than 10 minutes to complete. So thank you in advance for completing this for us. Next slide, please. Sepsis is a critical and elusive disease. Anyone at any time can develop sepsis, but the very young and the elderly, as well as those people with a weakened immune system or a chronic disease, are most at risk. I know you've all seen these stats before. They're staggering when you think about every 20 seconds, someone in the United States gets sepsis, and every 2 minutes, someone dies from sepsis. Since we started this webinar, approximately 30 people were diagnosed with sepsis, and 5 people have died. Sepsis is the leading cause of death in hospitals. However, it's not just a hospital issue. 87% of sepsis cases start in the community. It impacts 19% of our 30-day readmission rate as well. Rapid diagnosis and treatment of infection, vaccines, and hand hygiene can help prevent sepsis. But once it's started, mortality associated with sepsis increases 8% for each hour of delayed treatment. That's why we're talking about rapidly identifying sepsis within the hospital walls. This is how we will save lives. Next slide. Knowing that sepsis mortality increases by 8% with each hour treatment is delayed stresses how important early recognition is. Just treating sepsis once it's diagnosed is not enough. Everyone, including your clinicians, need to be reminded that the clock is ticking on this challenging diagnosis, and that the way to save lives is with early recognition and early treatment. Next slide. You should be screening early and often for patients that are at risk for developing sepsis. Don't wait for them to look septic. We want to catch them before they progress to severe sepsis and shock. We don't want to wait till the patient is non-responsive on a ventilator with fluids wide open. We should be catching the septic patient while they are awake with a nasal cannula, receiving IV boluses, so that they never progress any further. So we now want to get an idea from all of you of how many are actively screening patients for sepsis and what type of tool or assessment you're using if you are. So if you could answer this polling question, and if your screening method isn't listed here, just please put it in chat. And by the way, you can pick more than one screening method if you're using a combination of methods. So we'll give a couple minutes for you all to answer this polling question. If you're screening for sepsis, which criteria or tools are you using? And I think that we'll get the answers, right? All right, so 50% of you are using SIRS, which is the Systemic Inflammatory Response Syndrome. There are a couple of you using Muse, and 44% are using your own hospital-based tool, which we would be really excited to take a look at. And then there's a few of you who are not really using a screening tool at this point. So maybe we can help you out with that. And by the end of this webinar, you'll find a tool that you want to use. Thank you. And you can go on to the next slide. So keeping in mind that time is tissue, and sepsis is a medical emergency, it's imperative that your sepsis program includes some type of rapid screening and identification of patients with signs and symptoms of sepsis. So here's a few of those alphabet soup type resources to help hospitals put a process in place to rapidly identify the septic patient. So the SIRS criteria, the Systemic Inflammatory Response Syndrome, is based on these four criteria, either an increased or decreased temperature, increased heart rate, increased respiration or increased respiratory effort, or increased or decreased WBCs. And the idea with SIRS is that if a patient meets two of these criteria, you would screen them for sepsis. SIRS has been around since the 90s, And while it does help identify possible sepsis, it's also very generic, and many patients trigger for rule out sepsis when you're using this tool alone. Some practitioners don't find it helpful because of that. The SOFA, or Sequential Organ Failure Assessment, and Muse, or Modified Early Warning System, both include a scoring system for better risk assessment. And the QSOFA is a quick, shortened version of the SOFA score to be used on the floors and the ICU. Next slide. On its own, the SOFA score does not diagnose sepsis, but used in conjunction with assessment and disease-specific predictive factors, this is a good tool to help indicate the severity of sepsis diagnosis and also predict the risk of death. So the SOFA score assesses six symptoms: the respiratory system, the coag system, liver system, cardiovascular, central nervous system, and renal system. And you can see here that each one of the assessment results is given a score. And then combined, the higher the score, the higher the risk of death. Next slide. The QSOFA is just a shortened tool. It's a shortened version of the SOFA tool, and it's been used as a predictor of risk of developing organ failure and septic shock, leading to increased mortality. QSOFA assesses respiratory rate, altered mental status, and blood pressure. The QSOFA should not be considered a sepsis screen yet, though, and it should never be used on its own. Next slide. Similar to the SOFA score, the Muse tool scores patients at risk for developing sepsis by assigning a score to each one of 6 vital signs. So this tool should be used in conjunction with a physical assessment and clinical judgment as a tool to identify severity of disease and possibly mortality predictor. So after assessing and assigning a value, a Muse score of greater than or equal to 5 is associated with an increased risk of death. Next slide. I always like these stoplight tools. So a lower Muse score warrants continued monitoring, and then up through a high Muse score identifies action that needs to be taken to prevent sepsis. Next slide. Whatever screening process you land on and use, make sure that you include the entire hospital in the process development, education, and rollout. There should also be an audit of the screening process to evaluate the effectiveness, and then follow up the screening process with clear next steps for clinicians, nursing, and ancillary staff. Next slide. So using some type of screening, whether it's your own hospital screening that's built into your EHR, or you're using the SIRS criteria to identify your at-risk patients, the next step is to assess if there's a potential source of infection that would contribute to the development of sepsis. Next slide. On your intake assessment, you should be assessing all patients for any history of a possible infection. This can be bacterial, viral, or fungal in nature, and can encompass just the skin and soft tissue, or more systemic infections of the brain, heart, or lungs. Next slide. Along with your intake history of infection, you would correlate these signs and symptoms of infection, things like increased temp, increased heart rate, increased respiratory rate, increased or decreased WBCs, and mental status, that will help you confirm infection. Next slide. You might also want to consider obtaining additional lab work chest x-rays, or CT scans to help you confirm a diagnosis of infection. Next slide. If your patient has triggered for sepsis from your screening tool and also shows a potential source of infection, you now have a documented sepsis case, and you would initiate your sepsis pathway. The clock is now ticking. The next thing you want to confirm is if your patient has any related organ dysfunction. Next slide. Following identification of a patient with sepsis, the clinician must assess the patient for the presence of acute organ dysfunction or severe sepsis. The presence of acute organ dysfunction is often recognized clinically by the patients presenting signs and symptoms. However, in some instances, lab data and results of invasive monitoring will confirm the diagnosis of organ dysfunction. So you can see by the illustration here, which is a great tool to keep around and use, different tests give you different clues to the presence of different organ dysfunction. So altered consciousness, confusion, psychosis, or delirium would show that the central nervous system is involved. Tachypnea, hypoxemia, and oxygen saturation decreased will show respiratory involvement. Jaundice, increased liver enzymes will show liver involvement. Tachycardia, hypotension, altered venous pressure would show cardiovascular involvement. Anuria, increased creatinine would show kidney involvement. And thrombocytopenia and abnormal coag tests would show hematological involvement. Next slide, please. Here also is a list of additional tests and assessments that you might want to run just to confirm organ dysfunction in your septic patient. Next slide. So if your assessment of the patient does identify organ involvement and dysfunction, your patient is now in severe sepsis and needs to be evaluated for septic shock. Next slide. Now that you have identified severe sepsis with organ dysfunction, you want to assess for the evidence of shock. So is your patient still hypotensive after the initial fluid bolus? Or was the initial lactate greater than or equal to 4? Your patient may be in shock. This patient should be transferred to the ICU if they are not there already. Or if you're a critical access hospital, you should be transporting this patient to a hospital with the ability to manage a septic shock case. Next slide. So let's review. You should have a screening process in place that includes the SIRS criteria and can help identify all patients at risk for sepsis. The next step is identifying a source of infection. And once an infection is confirmed and the patient has 2 or more SIRS criteria or a high SOFA or Muse score, you will assess for organ involvement and dysfunction. If this is confirmed, you'll assess for shock. Next slide. The Surviving Sepsis campaign has many wonderful tools and resources. And here's one that outlines that entire process we just reviewed. This would be a really helpful tool to download and possibly laminate and put in your nurse's station or med room or charting area. Make it available for all levels of staff because it's a really nice tool to be using. Next slide. Another way to think about sepsis is as a continuum. So beginning with the localized infection that triggers a systemic response, so then you have the SIRS criteria. Once the patient experiences organ dysfunction due to sepsis, that patient has the clinical diagnosis of severe sepsis and qualifies for that diagnosis. And then several examples of potential organ systems are listed here. But next slide, please. But sepsis can happen at any time to any patient in any location. Next slide. We often concentrate our efforts on the emergency department and rely on them to rapidly identify and treat sepsis, and also to meet those bundle component elements. But sepsis can occur with any patient on any unit at any time during their hospital admission. So we also need to focus our efforts on interventions such as frequent sepsis screening on the medical units as well. No matter where the patient begins to develop sepsis, early identification and management improves their chance of survival. Instituting a nurse-driven daily sepsis assessment is a best practice of high-performing hospitals. Next slide. We have an example of a nursing shift assessment here to screen for sepsis. Many of you might already have a similar tool like this that's built into your EHR. If you don't, you can use a paper type copy or just include it in your regular daily assessment with your nurses. Next slide. But a sepsis screening should be a component of daily nursing practice that each nurse does each shift. Additional sepsis assessments should occur with any significant change in a patient's condition, and also for every time a rapid response is called. Nursing should be reminded that they are assessing their patient for risk of developing sepsis, and then know how to trigger the response system if sepsis is identified and initiate treatment. Next slide. We've also provided a really nice inpatient screening tool that can be used on any floor, the ICU or medical floors. There's a second page to this tool, and that actually is a septic shock checklist, and that's helpful also. So if you don't already have this built into an EMR, you might want to look at this kind of tool to download and use. And there's a link here to download this tool. And for those of you who like an algorithm, and that would be me, here's a really nice algorithm for posting and educating staff. This one is on our HQuinn Resource Center. It's a nice, simple algorithm, and it would be appropriate for use on the units or the floors, including the emergency department. Next slide, please. So it's all about early and identifying partners to work with the hospital team to identify and begin treatment even before the patient comes through the hospital doors. Next slide. You could think about working with your EMS provider to have them screen and begin fluids for hypotensive patients. And if they have the ability to draw labs to include a lactic acid in that on their way to the hospital. Educating the physician practices in your network about sepsis signs and symptoms is a best practice. And you can partner with your local long-term care and home care facilities and provide them education on early identification and management of sepsis. So we have another polling question for you. We want to get an idea of what processes your hospital already has in place. You can pick all that apply to your hospital, but once again, we really appreciate if you have additional processes in place that you put them in chat so we can talk about them later. And we'll give a minute or so to let everybody answer this question. Thank you. And we should be getting some results soon. So 95% of you have a screening process in place in the emergency department. That's awesome. 67% have it in the ICU, 81% on the floors. A couple of you, 24%, have partnered with your emergency your emergency services to manage sepsis in the field. That's a great best practice. We don't have anybody who's partnered with long-term care yet, so that's something we can definitely work on in the future. And but you have partnered with and done some work with your physician practices. And then some of you have a multidisciplinary team that's that is addressing sepsis for a sepsis program. Is that the last question there? Because that's all that's showing up for me.
Yes, the last.
Yep. Okay.
Yes.
Thank you.
Mm-hmm.
Great. Thanks for sharing. So next slide, please. The Surviving Sepsis campaign supports the implementation of the Hour One bundle on hospital floors. So the link to this is included at the bottom of this slide. This guide identifies best practices, implementing a QI program, defining team member roles, overcoming barriers in screenings. And I don't want you to confuse this with your SEP1 bundle compliance reporting, because that's not what this is. This is a guide to early identification and treatment to prevent sepsis from escalating to severe sepsis and septic shock. It's called the Hour One bundle because really it's just pushing all of those elements from the 3-hour bundle into as quickly as you can get them implemented. So you can go to the next slide. If we strive to identify sepsis and begin treatment immediately and have all those components of the 3-hour bundle in place and completed within the hour, it's a win for you because you're going to meet your 3-hour bundle component compliance measure, and also a huge win for the patient in reducing the risk of death from sepsis. So, because remember, 8% increase in the risk of death for every hour that treatment is delayed. This is a great graphic here that'll help you and your team to promote that Hour One bundle. There are some hospitals that we've talked to on our monthly meeting that are using this in place of the 3-hour bundle. Next slide, please. One of the best resources for evidence-based practices is the Sepsis Alliance. So we've provided a link here to the Sepsis Alliance, and then there's one of their resources are pictured on this slide. It's a fact sheet for sepsis, which you could print off and use for staff education, and it would be also excellent for patient education. Next slide, please. And the CDC, as always, is another valuable resource for developing your sepsis program for rapid response. Before we start the discussion part of this session, though, because we're kind of done with this part of it, I do have 2 more polling questions for you, and thanks for bearing with us. They're going to be back to back. The first one is about your gaps in meeting the SEP1 bundle elements, and this is going to help guide us in our next Affinity group call, which will focus on the bundle compliance. So let's wait a little bit and get this one answered. And you, like the other ones, multiple choice, you can pick as many of these things that you have in place. And you can write anything otherwise into chat. Thank you, everyone. And we can probably go ahead and get the answers to this one.
It looks like a few people are still answering.
Oh,
but-
okay. I will wait for you then. Dead air space makes me a little nervous. All right, awesome. We have somebody doing every single one of these. So, or not doing them, but having issues with every one of these. I guess it's not as awesome as I think. But our subject matter expert has asked us about this. That's going to be doing our next presentation. So we'll share this with him. And then we have another polling question that's going to help us out with our third affinity group call. That one is on auditing, measure, and feedback for success. So if you'd answer these, how does your hospital collect data for sepsis bundle compliance? And you would select all that apply here too. And if you do have a different way that you're collecting that data and tracking it, if you would put that in chat for us. All right, so most of you are doing it retrospectively through paper chart review. Then we have some that are pulling it from their EHR, so you can actually track it through your EHR. There are a couple of you that don't have a way to efficiently collect the bundle compliance, and some of you would like assistance with a bundle compliance tracking tool. So we will take this into account and use this for our third affinity group call. Thank you. Thanks everyone for helping us out with that. Next slide, please. So before we go on to discussion, I just want to bring everybody's attention to World Sepsis Day. It would be nice if we could make a difference and save some lives before World Sepsis Day on September 13th. So on this slide, I've put 2 resources for World Sepsis Day. One is a really short YouTube video that I found, very effective and you could use with your staff. And the other is a toolkit with resources for education, media resources, pocket cards. I mean, you could definitely get lost in that site. There's a lot of really cool resources to promote World Sepsis Day. So next slide. This is where we come to the part of the program where we're hoping that our hospitals will be taking the lead in. So we want to hear from you. We want to know what you're struggling with in identifying sepsis early. We also want to know what's been successful in your hospital and what you've accomplished so far, because sharing this type of information among your peers is helpful for all of us. As a reminder, you can type your questions or comments in chat, or you can use the raise your hand function that's down there under the reactions, and someone will open up your line so that we can talk on the line. All right.
Hi,
So,
Deb. There is a
hey.
really pertinent and timely question in the chat, and it is, have any of the screening tools changed to incorporate or anticipate routine symptoms of COVID and how those patients already mimic sepsis?
I did not see anything like that while I was doing the research for this. And COVID was not one of those infections that was listed on that slide that I had for you. But I can do more research pertinent to it. These tools that I've shared today do not include that, no. Anybody else have any thoughts on that?
There is some information on the Sepsis Alliance website that shows a correlation, but it's not a tool. It's really more of a research type paper.
So there's probably more information to come the longer we are in COVID processes. And I do know that, you know, from discussion on our monthly calls, that there are hospitals that do attribute their increased sepsis to the rise of COVID. Sometimes that's because they may, you know, be concentrating on COVID and miss that sepsis, that early sepsis diagnosis and things like that. And sometimes it's the co-infections that they're looking at. So I know that many do feel like there's a correlation there. Thoughts from others?
I did see one hospital responded that confirmed and PUIs for COVID automatically fall out of their sepsis bundle.
And who, can we get a little discussion on that? So that's your hospital-based sepsis bundle, correct? Okay, I'm sorry, I didn't see that.
Oh, the response is yes, it is. We have our certification scheduled for August 19th, and we are using Surviving Sepsis campaign.
Okay. Other discussion on that. And so there's another one that throws out COVID infections as well. At the same time though, and I'm sorry, I don't have that surviving sepsis in front of me. So hopefully this doesn't sound off base, but you're still screening for any other infectious process, correct? Yes, correct. Okay, thanks, Tiffany. And then there's someone who does include sepsis that they're not filtered out. Because obviously using SIRS criteria, probably every COVID patient is going to meet at least 2 of those criteria, which is one of the issues with that criteria and why you need to use a second type of screening tool with it to really drill down and risk adjust. Any other thoughts on the COVID co-infection?
There's another question regarding sepsis that indicates that their facility may be relatively new to the whole sepsis discussion. And where do I locate what should be included?
As far as the early identification, correct?
If they have COVID or suspected COVID, is it thrown out? Is it supposed to be included?
So we're going to have to do a little bit more digging. I think we need to pull up that link on the Sepsis Alliance specific to COVID. And we can get back to everybody on the next affinity group call with that. And that actually will be about the bundle compliance. So we can put that into that. I will definitely let the subject matter expert know about the questions about COVID and with that. I don't think that we can make a statement today on whether or not it should or shouldn't be included. Anybody else on the HQuin team have a different thought?
It certainly seems like an area for opportunity to standardize, since obviously hospitals are doing different things.
Mm-hmm. And Brianna will look into that too. She's saying CMS has excluded them from the bundle. But we'll have that subject matter expert speak to that.
Deb, we have another really good question, and it speaks to the fact that different facilities are in a different place with their sepsis initiatives. This one says, where do we start with pulling a team together? Does it have to be a large group?
So starting with making sure that you have leadership support is the best place to start with your team. It does not have to be a huge, large team, but it can't just be one person either. And I know a lot of the critical access hospitals that we're working with have limited staffing. They have limited people that have the ability to join teams. So finding a couple champions, people that are really passionate about, for in this case, it would be sepsis, but whatever team you're building for quality improvement, finding a couple champions to help you and work with you. And some of them can even be ad hoc. They don't have to necessarily attend each and every meeting, because sometimes it's difficult for people to get that time away from whatever their duties are in the hospital to begin with to have meeting time. But they can contribute by reviewing some of your protocols that you want to put in place. Getting that leadership buy-in and support, helps to have the ability to pull in staff members and leadership to support that time that those staff members are putting into it. Making sure that you're not just assigning a warm body to it, but it is somebody who would want to champion it. And then working through the actual QI process, which is what's nice about having an action plan. And the action plan that we can share with you outlines the QI process to begin with, setting your goals, putting a timeline to it, discussing it with your quality improvement advisor monthly, because that keeps you on track and it keeps you accountable. That's where I would start. Others on the team have input into that?
This is Mary. I know in my experience that a lot of facilities have ladder type programs or other incentives for nurses and other clinical team members to participate in programs like this that will benefit the hospital and the organization as a whole.
That's an excellent idea. So who asked that question? Want to make sure that we answered appropriately. And does anybody in our audience have any suggestions for that? Where have you started your team? So Tiffany, our committee consists of a sepsis coordinator, a quality manager, a hospitalist, an ED physician, ED directors, the president, CNO, and ICU and floor manager. And then you have 2 champions. So that's a large team. Thank you, Tiffany. And how often are you meeting then, Tiffany? Because that's the other thing. In the beginning, you probably want to meet more often, to get things started, and then can possibly meet monthly thereafter.
Deb, there was another great question if you're ready to move on.
Try monthly, but with COVID, I believe that, Tiffany. Yeah. And we find that with our monthly meetings. It seemed like we were getting ready to move forward with some quality improvement work beyond COVID, but in some of the states now, the positivity rate has really climbed. And so we do understand that too. And Erica has just said that she added a clinical documentation specialist into her team, which is really a good idea for any quality improvement team if you do have that ability to have that person on staff. And Kate says that they have an interdisciplinary team with hospitalists, ED physicians, CNO, nursing directors, quality and infection control. And yes, COVID reporting is again ramped up. And Brianne, 30 people on the team, including your CNO, department managers, nurse champions, hospitalists, ED providers, and IT. Yeah, the clinical documentation specialist is a good idea. I do know, though, that a lot of our smaller critical access hospitals, that would be the entire hospital staff trying to get 30 people onto a team. So some of these recurring members, like having somebody from the ED, having a champion, if you do have somebody who's doing clinical documentation, that type of thing for the smaller hospitals, you're going to have to do with a few less. But like I said, some of them could be ad hoc so that you're just pulling them in for review and help when it's time to roll out the educations, things like that. And Katie.
Deb, we have a question that came in.
Okay, go ahead.
We have a question that came in. Are there screenings for early detection of sepsis? Sorry, my screen just moved on me. Are there screenings for early detection of sepsis for patients who are not yet in the hospital? I'm thinking about those primary care providers or specialty clinics, maybe seeing patients at greater risk for sepsis and how their case management resources can help identify sepsis even when the patient is still at home.
So my thought would be that the screening with SIRS is still appropriate. So it would still follow that basic steps in it. If they do meet 2 of the criteria for SIRS, and then the next step is to assess for infection. If infection is a possibility with 2 SIRS criteria, they should be considering sepsis. This type of education is appropriate for those settings also. Screening for sepsis is going to be the same no matter where you are. And maybe let's get some discussion on that. Has there was a couple people that did mention that they had worked with physician practices. What did you do with the physician practices in either associated with your hospital or in your community to help them be able to identify sepsis early? And does anybody think that the same screening tools that you're using in the hospital would not be appropriate for a physician practice? So we actually had in the past, HQI worked with a project that was reducing sepsis in hospitals and nursing homes, where we brought hospitals and nursing homes together to reduce sepsis and early identification. And we had tools that from the Seeing Sepsis 100 program, which were very simplified tools on if the temp was greater than 100, the heart rate was greater than 100, and the blood pressure was less than 100, you should think sepsis. Changes in condition, in the nursing home, of course, they're seeing them more often, but in the doctor's office, that would be a little bit harder to assess. But once you hit that type of criteria, then you start screening for possible sources of infection.
Deb, there was another question earlier on that I wanted to make sure others could possibly provide suggestions for. Our biggest issue is timely recognition and treatment when the patient moves into the severe sepsis pathway after admission to the floor. Other than the constant education and reiteration in the monthly team meetings, I'm at a loss as to how to fix this problem. Any suggestions?
Does anybody on the call have a suggestion for that? I guess my question would be, is it in the shift nursing assessment? And I'm assuming it is. If they've been educating on it, yes, it is. Yeah. And do they understand why they're doing that assessment? I guess that would be my question. It sounds like you've done quite a bit of work on this and educated and re-educated. Does anybody in the audience have any? And which is an excellent question, whether or not they understand why they're doing it. Yeah. So maybe just making sure that they do understand that, the why behind it, and then the next step, just like within the presentation, we talked about, that they know how to, first of all, initiate the pathway if they need to, and then what are their next steps. And speaking about that, how does so this person includes sepsis and nursing orientation and focuses on the screenings. And sometimes then do you also have those yearly skill fairs for nursing, maybe pulling sepsis into that? I mean, it is a very important diagnosis. It really impacts data and people's lives. So maybe having during the annual skills day, also having some type of a, session on sepsis.
Deb, just a time check. We only have 1 minute to go.
Oh no, this went quick. I'm so sorry. We'll look back through all of these questions and discussions. Thank you, everybody. We've got our homework to do, obviously, in moving forward. So I'm going to turn this back over to you, Karen, to wrap us up. Thanks, everyone.
Sounds good. Thank you so much to those of you that shared your comments, your questions, and your experiences, because your active participation makes all the difference, as I think we could clearly see today. As we mentioned earlier in the presentation, with any good work group, we have a homework assignment. So Deb talked about our takeaways of what we're going to pull for you and have ready for the next session. And so we do ask that you complete the online gap analysis by next Friday, Friday the 13th. And the link is provided in the chat, although I know there are some issues with access to that. So we're going to work on that pretty much as soon as we get off this call to make sure you can have access to that. But nonetheless, we'll also send you the link to that in a follow-up email, and there'll also be the link to that gap analysis in this slide deck as well. And you'll receive a copy of the slides too. Next slide. We've also included additional resource links for review and use. And next slide. And finally, our next Sepsis Affinity Group session call is scheduled for August the 19th at 1:30. The topic will be implementation and improvement of sepsis bundles. And our guest speaker is going to be John Lawrence, who is an RN sepsis coordinator for the Inova Health System in Alexandria, Virginia. And as Deb mentioned, we're very excited about having him join the call and speak to some of the very questions that you asked about, where we'll be taking some of your feedback to him. So we thank you so much. If you have any questions, please feel free to follow up with your quality improvement advisor or anyone that's been working on the call today. We're more than happy to get you the resources you need or to field any of those questions you have. We look forward to working with you, and we'll talk to you again on the 19th. Thank you.